Hello, I'm Andy Ziskind, a cardiologist and Associate Dean for Clinical Affairs at the University of Washington School of Medicine. Welcome to the Mini Medical School, a series of lectures and demonstrations delivered by medical professionals who are experts in their fields. These presentations were given to a small audience this past winter, and because the response was so positive, we want to share them with you. After watching this program series, we hope you'll be more knowledgeable about medical problems that may affect you and your family. I hope this knowledge will help you play a more active role in your healthcare. I'll be your host for the duration of this series. This hour's topic is orthopedics. Dr. Rick Matsen, professor and chair of the University of Washington Department of Orthopedics and Sports Medicine, will go over the details of shoulder replacement surgery. His talk will be highlighted by a video of the procedure and an opportunity to meet with two patients. We will also learn how the doctor, patient, and staff all help to make the art of restoring function a success. Let's watch.
Our department is called the Department of Orthopedics and Sports Medicine, and we are about trying to restore function. You have other departments that are interested in saving lives. We have a different objective, which is trying to make life as good for people as we can while they're here. And so we have our department sort of divided into various areas of orientation. One is about arthritis, one is about trauma, one is about sports medicine, one is about pediatric orthopedics, and tumors. We also have our department sort of organized in another way along geographical areas, including hand and wrist and shoulder and elbow, hip and knee, spine, and foot and ankle. So we're fairly broad-based and sort of come at these entities from these two different kinds of dimensions. We like to think about there being an engine in orthopedics, so we like to think about ourselves as having innovations in better ways of taking care of patients. We try to follow up our patients very religiously, asking them to participate with us in the evaluation of the treatment so we can learn where the shortcomings are and direct research at those shortcomings and then try to keep that cycle going. So we're very interested in this, which we call the Orthopedic Engine. And this engine is fueled by grant funds, by funds that we choose to take from our clinical practice and invest in research, and also by development funds. And we've been very fortunate in our department in having a number of endowed chairs that have been very helpful to us in getting us to where we are today in terms of, again, fueling this orthopedic engine. And I'm just listing here a few of the endowed chairs that we are so excited to have in our department. Andy mentioned my daughter. I got very interested in women's sports medicine and lifetime fitness as a result of her trials and tribulations as an athlete, and so I'm really pleased that we're now in the process of looking for the first holder for that chair. And tonight we're going to be talking a little bit about what's happened with the Harriman chair as a result of some of the progress we've been able to make with that kind of support. So as a specific example of how we try to restore function in orthopedics, we're going to talk a little bit about what we do for people who have arthritis of the shoulder. Now, one of the key concepts in our departments is we're trying to make the patient the center of our entire operation. In other words, it's all about the patient and about their family. And it actually begins long before we even see the patient, because we try to get them to characterize their own shoulder function so we can have them list out the things that they can do and the things they can't do, because those things that they can't do become our surgical objective. Those are the things we want to help them conquer. So it begins with a patient self-assessment, and we have what we call a simple shoulder test, which is just 12 yes or no questions that we ask people to answer about their shoulder, giving us in just a few minutes of their time a very crisp reflection of what the status is. And this enables us to understand the things that bother patients and, again, to direct our therapy appropriately. And so in this slide you can see the results from 1,389 patients who have helped us try to understand what it means to have arthritis of the shoulder. And I think you can see here on the right-hand side of the screen that these people have significant loss of function. For example, only 11% of people with arthritis of the shoulder are able to sleep comfortably, and only 10% are able to wash the back of their other shoulder. So these are real functional things that most of us take for granted that we're able to do every day or every night, but when these functions are lost, they make a huge difference in the quality of our life. So again, part of our research is taking all these low percents, in other words, these small numbers, and convert them from no's into yeses. Now, we call this the simple shoulder test because one of the challenges in doing outcome research is that it's very difficult to get patients to participate in follow-up, and largely because the follow-up process is too difficult, and many of our patients are from a long ways away, or they are very busy, and they don't have time to fill out lengthy questionnaires, and they don't have time to come back to the office every year or every 6 months for routine follow-up. So most of our patients are very helpful to us in agreeing to follow along with us the progress of their shoulder after surgery so we can see where it's good and where it can be made even better. So this is what the x-ray of a normal shoulder looks like for perspective, and there are a couple of things that you can see about it is that the ball is nice and round and that there's this big space between the ball and the socket, and that space is occupied by cartilage. And cartilage is an incredibly smooth surface. Matter of fact, the coefficient of friction of cartilage on cartilage is 1/10 that of an ice skater skating on ice. So it's about the lowest, most friction-free surface you can possibly imagine when it's normal. But when it's arthritic, as is shown here, you can see what's happened to that cartilage space. It's gone. And now we have bone rubbing on bone, and the coefficient of friction of bone rubbing on bone is extremely high. And it creates a catching, popping, grinding sensation as people try to move. And it's very hard to get a shoulder like this in a comfortable position. You can also see down at the bottom here, we've got bone spurs, which again compromise the range of motion. So this is an unhappy shoulder and one that's going to interfere with the person's ability to carry out just about every activity of daily living. And most of the people that we've done shoulder replacements on say, I didn't realize how much of a problem I had until after it was gone. Now, this is what an arthritic socket looks like, and you can see that it has a very rough surface on it. It doesn't look at all like normal smooth cartilage. And here's what an arthritic ball looks like, and you can see again that this is very rough and irregular, not at all like we would like to have in a normal joint. And if we look at the ball after we've taken out, you can see that in the central area here, there is absolutely no cartilage at all. There's a little bit of cartilage around the periphery here, but none in the middle. We call this sort of a Friar Tuck kind of appearance. I don't know if any of you remember the monk from Robin Hood that had a bald spot in the middle of his head. So this is the Friar Tuck appearance that we see so often. And what's interesting is that this area, this bald spot, is exactly in the middle of the ball. It's exactly the part of the shoulder that is used most commonly. So unfortunately, the shoulder wears out in the place where you need it the most first. The first shoulder replacement was done by this guy by the name of Payam back in the 1700s. This is interesting because this painting of him was done by Toulouse-Lautrec, and he had a patient that had tuberculosis, and he had the idea of replacing it with this kind of prosthesis, which actually was made out of all things, rubber and platinum. Now, how he ever came up with the idea that you should replace a shoulder with rubber and platinum, I wouldn't know, but in any event, it worked for a while until it got infected, and then it had to be taken out. But at least people a long time ago were thinking about the possibility of replacing the shoulder joint. Now we've had the opportunity to participate a little bit in the design of shoulder replacement components, and what we do is to use a metal ball, as is shown here, and a high-density polyethylene socket, as is shown here, and place them in the shoulder. And here you can see this is the outline of the normal bone here, and we've put this metal stem down inside the bone, and here's the nice smooth head, which is this part, and you can see this space is now occupied by the polyethylene, which provides a very, very low friction kind of interface, which is not quite as good as the normal cartilage, but it's getting there. So this is a really nice shoulder arthroplasty that provides the patient with a very low coefficient of friction and the ability to regain the range of motion and the strength that they had in their muscles before they became arthritic. So one of the things that we need to do before we do this kind of surgery, obviously, is to not only assess the patient, but bring them into the decision. And that's one of the key parts of our program, is we want to engage in what we refer to as shared decision making. Because in the old days, patients used to come to the doctor and say, do whatever you think is right. But I don't think that that's right anymore. I think the right thing to do is to say, these are the options, this is the potential risks, and these are the potential gains of the procedure. Tell me what questions you have for us that we can help you answer about the prospect of having a shoulder replacement. Now, one of the things that we've been very active in, and this is thanks to in large part a grant that we've received from the University of Washington, is to try to develop a patient information website. And the goal here is to enable patients to find this information from their homes and to access it and really take at their own leisure time to peruse this material and look at it over and over again. So I'm just sort of surfing through this website now, and so here is the handout that actually is reproduced in the material that I gave you today. But here is a lot of material that a patient, regardless of whether they live in Duluth or Tallahassee or Renton, can find. And this approach to informing the patient has become very powerful for our program. And many patients will come in with the website printed out and say that they understand these details and would like to talk more about the specifics. So we have put, again, a lot of information in here, and the beauty of this is that the patients can not only see it once when they're with us in the office, but they can go back to it over and over again and refresh their mind about what the elements are of the procedure, and including what's involved in recovering from the surgery. So again, we have details there that people can access and re-access. So it isn't the situation that we used to encounter all the time. The patient would come to the doctor and go home, and the family would say, "What'd he say?" And the patient wouldn't remember, because it's a lot of information to take place. And I realize, having been at the other end of the doctor-patient equation a number of occasions, it's sometimes very traumatic to be sitting there as the patient and somebody saying, well, you know, you could lose your arm, or you could get an infection, or this could happen or that could happen, and you tend not to remember things very, very clearly. So our goal is to try to make sure that the patient has all the information, and one of the things we try to remind everybody is there's nothing emergent about having their shoulder replaced, and we want you to take all the time you possibly can. And again, if possible, we want to be able to share experiences among patients, as we'll be doing this afternoon. So one of the other points, and one of the questions that we get very often, is who should do my shoulder replacement? And this is a hard question to answer, but I think it is interesting to share with you, as we share with our students and others, that there is a funny distribution of shoulder replacements in the United States because there are not so many of them done. So if you look at the number of shoulder surgeons that really have a substantial experience in doing this kind of surgery, it's quite small. Matter of fact, when we looked at the data from the state of New York, only 3% of the people that did this surgery did more than 10 of them a year. And you can imagine how good of a golfer Tiger Woods would be if he hit a golf ball less than 10 times a year. And so 77% of the shoulder replacement surgeries done in New York are done by people who do 2 or less a year. So again, this is quite different than hip or knee replacement, because there are lots of hips and lots of knees done. So you have sort of an imbalance, and one of the questions that